Great. Well, thank you, Marla. So in the next 15 to 20 minutes, I'd like to provide an overview on biologics in the clinic. I have some data up front, which you've seen, but really I'm going to end with my practical approach in positioning the biologic therapies, which is, I think, what we all want to know and what we're asking every day. I'll start by saying there are no data to support the end part of my talk, but I'll provide, again, my opinion. So you've seen these slides before, and when we think about biologic therapies, we're really talking about the anti-TNFs and the anti-alpha-4 beta-7 or anti-alpha-4 integrins. And I want to thank Uma and David because some of these slides they provided me as well. But really the integrins are the Vedolizumab and Nondisabling. So the question is, how do we position these, especially in the newly diagnosed patient? And I'll just briefly touch on a few cases, and as I pop them up, think about whether this would be a patient you would target for biologic therapy early, or whether this is a patient you would hold off on biologic therapy early, and if so, either way, maybe why. So how about the 18-year-old who presents with severe ulcerative colitis and deep ulcers through the entire colon? Conversely, the 27-year-old with mild ulcerative proctitis. So those are probably easy to look at one versus the other in terms of treatment. How about the 34-year-old with mild Crohn's ileitis? And then the 29-year-old with fistula, ulcers in the colon and ileum. But what about the 71-year-old? So now we're getting into a different age strata in terms of pan-ulcerative colitis, 5 ASAs, and steroids. Would you give a biologic? If so, in combination? And if you were to give a biologic, are there considerations that we would have in terms of immunosuppression in somebody over the age of 60, 65? And then finally, the common presentation is a 31-year-old with moderate Crohn's ileocolitis who'd maybe been on a prior course of steroids. Do we jump to a biologic in this case or not? So I would say just by the, again, without any other information, maybe these are cases that we would think of biologics in the orange. But I guess, and I would submit that if we went around and anonymously asked each one of you, probably each of you would pick a different biologics strategy. Some would use combination, some would not, and there would be justification in every way. Well, let's think about, and when we think about positioning biologics, which is really the topic of this talk, let's think about why we would have even this discussion. And I think it really comes back to a study that was published in 2006, which looks at prognostic factors for aggressive disease. I'm not going to go through the whole study, but if you look at the middle column that says non-disabling and the right column disabling, focus on disabling Crohn's disease and some of the characteristics or prognostic features that all of you see in your practices and probably take into account when you see patients every day. So the patient under the age of 40, the patient with perianal disease in Crohn's, and those who have used steroids as a first-line treatment. These are people that we are seeing have a more disabling course. Now, does that translate into these are patients that should require biologic therapy? Maybe, and this is maybe the group that we would think about. We also know in a separate study that deep ulcerations and severe ulcerations, so Marla and David mentioned in their talks certain predictors in terms of aggressive course of disease, and this was a study, SEL just means endoscopic lesions, severe endoscopic lesions, which were defined by deep ulcerations. And you can see in the blue bars that if we go across over time, the probability of colectomy becomes much higher. So you probably see this, and we talk about this at conferences, and we talk about this in our own practices. You have a newly diagnosed patient, you do a colonoscopy, first you think, wow, maybe they have CMV, the ulcers look terrible, but they don't have CMV, and this is the first presentation of their Crohn's disease. That's a high likelihood toward colectomy. Ulcerative colitis, so those are Crohn's predictors, and I'm just briefly glossing over some of the factors now for ulcerative colitis. Ulcerative colitis is interesting. About 50%, about half of ulcerative colitis patients phenotypically and behavior of disease have a fairly benign course of disease. And what do I mean by fairly benign? Meaning they're patients who respond to 5 ASAs, don't need to escalate treatment, are not being admitted to the hospital, don't have ulcers or deep ulcers in their colon. And we see them every day, and these are patients who do well and do fine. We don't talk about them at conferences. The conference discussions are the other 50%, and what David presented, whether they've had ulcerative colitis for years and then boom, C. diff or non-C. diff, they develop all of a sudden very aggressive disease. And now we're thinking, wow, why are they so sick? Do they need a colectomy? What do I do in those cases? Well, there are also some data for ulcerative colitis and deep ulcerations. And I think one, I was part of an AGA pathway writing for ulcerative colitis recently that will hopefully be published at DDW, and we couldn't agree on anything. The one thing that we agreed on is when we see deep ulcers, that's a bad prognostic sign. And I know that sounds fairly simplistic, but I think that this really is going to pan out as one of the disease predictors. So in the left-hand study and the right-hand study, essentially what they both showed were, in the left-hand study, 93% of patients who had deep ulcerations in their colon ultimately underwent a colectomy. On the right-hand side, only 23% of patients who had milder ulcerations underwent a colectomy. So how do we position biologics and data from the clinical trial? So I promise I only have 2 of these slides since you've seen these a million times before, but this is a summation slide on the Crohn's disease studies. Infliximab top left, adalimumab top right, Vedolizumab bottom left, and Nondisabling in the bottom right. And what we see is that about 40 to 50% of patients across the biologic strata have induced a clinical remission or have a clinical response early on. These are not comparative effective information. I'm just saying that we see similarities if you look at it overall. This has been presented. The Sonic study, combination treatment is better than either alone. I think you've probably seen this 10 million times, so I won't spend much more time on that. And then now finally, Vedolizumab. Sorry for the small graph on the right side, but essentially it shows similar data, that about 40% of patients at an early time point have a response to Vedolizumab for Crohn's disease. What about ulcerative colitis? Top left and right are Infliximab for response and remission. Bottom left and right are adalimumab and then golimumab. And again, we see similarities between the biologics. Combination treatment, Dave Rubin already mentioned this, that we use combination treatment in Sonic for Crohn's, combination treatment in the success file for UC actually looked better. And then Vedolizumab, David showed this as well, is an effective agent for ulcerative colitis. So when we think about positioning biologics, I've given you some clues in terms of maybe we use them earlier with deep ulcers, maybe the younger age of onset, maybe the first dose of steroid, the more severe presentations with perianal disease. Those are becoming the trends by which I would submit are becoming fairly clear-cut predictors of early biologic use. The other thing we know is to treat earlier. Now, one thing I'll mention, and I think Marla mentioned this, and this is probably more important than anything we're doing here, and there may not be anybody in the room, I shouldn't assume anything, but is the payer part of this. So there is an expense, and in Pittsburgh, we're putting together this IBD home, and I'm meeting with the director of the pharmacy, not of our hospital, but the payer system, and almost monthly we have discussions on, now you're telling me there are 6 biologics now, there may be 2 more, and the cost keeps going up. We're going to be bankrupt if we keep paying for all of these. So this is an interesting discussion that we can maybe have in the question and answer period. I'm not going to present data because there aren't a lot of data in terms of cost long term, in terms of which biologic is more costly or which is less costly. But what we do know, and this is a slide you've seen before, is that preclinical treatment of Crohn's. So look on the left bottom. So patients come in, they're silent, they probably have Crohn's for years. Then you make a diagnosis because they finally present with a symptom of Crohn's disease. And what we see is that if we start treatment earlier, and I like Marla's analogy, I hadn't heard that before, the car's driving off the road and we can get them back on the road. But if we start treatment earlier, we may prevent that car crash where we can keep them on I-95 or whatever your favorite route is in the country. What we know is on the far right-hand side at the top of this, where they develop scar tissue is irreversible. And while we may be able to impact on the component of inflammation, we can't reverse the scar tissue. And there are plenty of studies, which I won't belabor except I put a lot of red circles. So Vedolizumab and adalimumab on the left, Vedolizumab on the right. When you look at less than 2 years for adalimumab, less than 1 year for Vedolizumab, even if you can't read the numbers at the top of the bars, you can see that earlier treatment has a much better outcome in terms of biologic response than patients over on the far right-hand side where that drops off. And that probably has to do with the common sense reality that once you get tissue restructuring and damage, it's irreversible. Similarly in children, so the pediatric colleagues have shown this already. Patients who are newly diagnosed as kids, look at the response rate in kids. 88% of kids respond to Infliximab early, less than 2 years of diagnosis, and then 59% went into remission. These are much higher than what we've seen in adults, not because adults maybe are different. Yes, they're different chronologically, but adults have had disease a lot longer and their disease is somewhat irreversible by that point. We've also seen that loss of response has to do with shorter duration. Shorter duration of disease, less likely loss of response over time. And then the final topic before I get into how I would position these in the clinic is mucosal-based treatment. And I think Marla hit this on the head. And this is probably where we're headed more than anywhere else in the field of inflammatory bowel disease. At the bottom, I put that patients want to feel better. Clearly, that's important. Now it's interesting. Patients are becoming more savvy and asking us, when are we going to get scoped again to see if the disease is healed? So this is an interesting time where we're looking at mucosal healing or this treat-to-target phenomenon. And this is just the definition, if you haven't seen this before, by Brian Fagan. What is meant by deep remission? It's restoration of normal bowel mucosa by endoscopy of a previously inflamed region and the complete absence of ulceration. Macroscopic and histologic signs of inflammation are gone. Now that's a high bar, and I would submit that we probably cannot achieve that in everybody, but I think if we can get as close to that as possible, patients will have better outcomes. You've probably seen this before. This is just the evolution of treatment. If you look at the left-hand side from clinical response to remission, now to deep remission. And I'm going to skip through these because David showed these already. And I'm going to get to now the important part is how do we position these in the last few minutes of my talk. One of the things that has come up, and I presented this in the different cases is, and Corey Siegel has done this and Gil alluded to this already, is some shared decision. And shared decision also has a lot to do with cost, yes, but also adverse events. So the anti-TNF category has been out for a while. We're very familiar with the adverse events linked to anti-TNFs, Nondisabling, PML. Vedolizumab, as I think the speakers before me have already mentioned, aside from some nasopharyngitis, at least at this early post-marketing time point, we haven't seen a big uptick in terms of infections or cancers. Now, in fairness, just to be transparent, we haven't had vedolizumab for 10 years, so I think we still are waiting, but at least the data from the early studies where there are data for a number of years and our post-marketing strategies have looked good. So I've told you why biologics. I've told you the options, better outcomes, healing the mucosa, weighing the risks and benefits. But the question is, which one should I use? And how do you position them? Well, there's an indication in terms of labeling. There's an efficacy question. Every single payer, and I'll say this again, every single payer I've talked to wants to know which is better, and that's the one we're going to put at the top of the formulary. We don't have that data. So we extrapolate, but that's what everybody's wanting, these comparative effective studies. Maybe there's some differences in how we position them in terms of demographics. Maybe adherence is an issue, and that's an important factor in some of our patients, especially our young patients. David already mentioned the severe patient. Maybe we look at that different in the hospital versus out. Subtypes of disease, and then ultimately pharmacokinetics. Marla talked about measuring drug levels is a good thing. Well, if we don't have an assay to measure the drug level, does that impact or influence how we look at it, but possibly the payer looks at it in terms of how long is this patient going to be on treatment. And then ultimately safety and the need for concomitant immunosuppression. I already mentioned cost, we can't forget that, but there are not enough data at this point to say cost or comparative effective. So this may be a hard table to read, but I've tried to put this together. Now this is my opinion, okay, so I'll say this again. These are not published data, but what I've done is split Infliximab, Vedolizumab, Severity, Golimumab, Nondisabling, and Vedo down the left side, and then I picked these categories. So the indication by the label, you can see that Infliximab, Vedolizumab, and Vedolizumab are approved for both UC and Crohn's, Severity for Crohn's, Nondisabling for Crohn's, and Golimumab for UC. So that's today. Severe extensive fistulizing disease are inpatients. Now, the reason I put Infliximab with 3 pluses and the others with 1 pluses is primarily because of David's talk, meaning that we have the ability to know with Infliximab we can ramp up the dose, maybe overcome that low albumin, the clearance of drug, and overcome some of those factors. I also completely agree with what David said, that maybe with some of the others where we used a fixed dose, not a weight-based dose, if we give higher doses of those, and there's an adalimumab study looking now at 160 each week for 4 weeks consecutive, maybe giving a higher dose will show the same results as with Infliximab. We don't know that yet. I think also fistulizing disease, we tend to favor just based on the studies Infliximab, but I would also submit that maybe higher doses of some of the others would work as well. Now what about safety? And in very small print that you can't read up there, it says thiopurines would increase risk of any of these, okay? And you could possibly say methotrexate, same thing. It is my opinion and in my practice, in all of these are monoclonal antibodies, and again, even Vedolizumab has some immunogenicity. I use combination treatment when I can with all of these. Sure, patient has Azathioprine-induced pancreatitis, they've developed interstitial lung disease on methotrexate, you're stuck. And I'm not gonna force the issue and say that every single one of my patients is on combination, but at least when I start, because I think immunogenicity is gonna be a factor with all of these, we should use combination treatment. Safety profile in anti-TNFs, we know. Vedolizumab, if they're JC virus negative, is probably a very safe drug. And we're seeing that Vedolizumab seems to be very safe. And this is now an agent that I am looking at. I started a 78-year-old who looks like they're 48. I started a 78-year-old on Vedolizumab last week, primarily because they're 78 years old. Full disclosure, that was something I took into account. Need for concomitant immunomodulators, I already put this up here. Now I'm saying yes to all of these. The data don't bear that out. The North American study with Vedolizumab purposely did not use a combination approach where the European study did. So some of this, again, is my opinion, not based on evidence-based data. Uma's already touched on the pregnancy, and I think she's even touched a little bit on Nondisabling and Vedolizumab, but I think Severity we feel is probably from a safety and pregnancy, maybe a 2+, but they're all, in my opinion, safe. Ability to measure drug levels, and Marla already mentioned this. Right now, today, and again, this will probably change, Infliximab and adalimumab are the 2 where we can measure levels. Does it mean we should just use those? Can we measure levels? Maybe not, I'm not saying that, but I will tell you the payers are becoming more interested in telling me when they come in and I look at costs in our medical home, they're like, Dr. Reguera, you're killing us with the cost, and they're saying, how do you know if the drug's working, and how are you gonna switch to something else, and how long are they gonna be on this? Then we get into a discussion about the levels. Now, they also don't like the levels very much because right now those cost them a lot as well, but when they look at the overall totality, that may influence, as it has in the oncologic homes, that may influence drug responsiveness long term. Adherence, it depends how you look at this. So IV, I put monitored care, meaning that there's a nurse either, now we're doing a lot more home-based infusions too for cost reasons, but there is some interaction with a healthcare professional that occurs through the IV where sub-Q it doesn't. Now, if the person getting IV doesn't come in because they don't want to come into the hospital or the outpatient clinic to get an IV treatment, well, then that's not very good, as long as we know they're taking their sub-Q. Now, there are each of the companies that have the sub-Q administration. We can also have nurses and healthcare providers help with this sub-Q. So maybe monitoring would be better with that. Extraintestinal manifestations, again, I'm putting this up as my opinion only. I think that there has to be some systemic benefit of the treatment. Now, you could argue if the disease in the colon is driving the extraintestinal manifestation, well, maybe something like vedolizumab and natalizumab would be a good thing. I think at the bottom right, you see a question mark PSC. And this is something we don't have data today, but I do know it will come, is vedolizumab is also taken up by the biliary tree. So it would be unique and interesting to think, ulcerative colitis, vedolizumab works. PSC seems to happen in ulcerative colitis. Would there be an impact on PSC? There are no data at this point. That's why I put a question mark. So this is one big table, which I just went through. And again, this is based on my opinion. But I put up on top, we still lack comparative efficacy and cost studies. So my final slide in the last 14 seconds is that we have prognostic factors. We individualize our care. Marla's already told us, and I agree, that symptom-based management is probably a thing of the past. We do need to use a shared decision approach. Gil mentioned Corey's data. And I think treatment monitoring, therapeutic drug monitoring is here to stay. It is something that we will use more proactively in the future. And then there will be other biologics that will add to this, which will have our payers pulling their hair out even more, but will give us more options for better treatment of our patients. So thank you very much.